Recording in progress.
Hi, can you all hear me?
Yes. Hey, hello.
Okay.
Yes, we can.
Okay, great. Thank you very much. So thank you everyone for attending our SGH World Psoriasis Day public webinar. As you know, psoriasis is a common chronic condition which affects the skin, nails, and joints. Research over the last 30 years have shed light into its association with our general and mental health and emphasized the need for holistic assessment and management. Today, we celebrate World Psoriasis Day. The theme for this year is psoriatic diseases and comorbidities. I'm very honored to introduce our panel of speakers for our talk today. Our first speaker is Dr. Kirsten Yeo. She is the Senior Consultant and Head of Department for SGH Dermatology. She will speak on the diagnosis and management of psoriasis. Later on, our second speaker would be Dr. Shashendra Afonso, who is a consultant with our department. He will be speaking on comorbidities beyond the skin. If you have questions during the talk, please key them into the chat and we will try our best to answer them at the end of the two talks. Without further ado, let me invite Dr. Yeo to start the talk. Dr. Yeo, please.
Okay. Hey, everyone can see my screen?
Yes.
Okay, great. Okay, so good afternoon to everyone, and thank you, Dr. Ang, for the introduction. So for this first talk, I'm going to start with the basics of psoriasis, and hopefully I can help you better understand psoriasis, including its symptoms as well as its treatments. So to start, psoriasis is a chronic scaly inflammation of the skin, which affects about 2 to 3% of the global population. And while most patients have very mild conditions, the persistent scaling and flaking can pose a daily nuisance, cause embarrassment, and significantly impact the quality of life. Furthermore, we know that psoriasis is now recognized as a systemic disorder, so not just a skin problem, but it can be associated with the increased risk of metabolic conditions as well as heart disease, especially if it is poorly controlled. And thus, good control of psoriasis is essential, not just to relieve the symptoms on the skin and improve the appearance, but also to reduce the inflammation within the body and the risk of some of these metabolic disorders. And you will learn more about them from Dr. Sashen in the talk later. So for this first part of the talk, I will be sharing with you, firstly, what are the symptoms of psoriasis and how can we recognize it? Secondly, why does psoriasis occur? What are the causes and risk factors? And lastly, when it does occur, what are the treatments that are available to treat it? So what does psoriasis look like? So in the most common form, psoriasis appears as raised red or pink patches with very thick silvery scales. And for some patients, these scratches may be itchy, although psoriasis does tend to be less itchy than some other skin conditions like eczema. In some patients which have darker skin type, sometimes the redness may not be so obvious and the rash may appear to be more dark colored or brown. Psoriasis also tends to affect certain locations, and this can be a clue to diagnosis. So in particular, it likes to affect the scalp, the elbows and the knees, the umbilicus, as well as the lower back. And when it does affect the scalp, as you can see in the picture below here, the rash tends to extend out of the hairline, okay, and into the surrounding skin. So there are various types of psoriasis, the most common type being that of chronic plaque psoriasis. So you can see here the typical features of the raised red scaly rash affecting the lower back as well as the elbows. And sometimes in younger patients, we get a different variant which we call guttate psoriasis. So this tends to be more small little psoriasis spots that look like raindrops and may be due to an infection. And sometimes we can also get involvement of the folds where we get red patches over the folds such as the groin or the armpits. There are also various types of psoriasis, such as pustular psoriasis. So pustular psoriasis is when we see small little white pus spots with psoriasis skin. And so this usually indicates that the psoriasis is a little bit more unstable. And when patients have severe psoriasis, sometimes it can affect the whole body, and this is what we call erythrodermic psoriasis. So while some of these psoriasis may look different, in some way they are all related, and in fact, one person sometimes may have more than one subtype of psoriasis. So apart from the skin, psoriasis may also affect the nails as well as the joints. So about 50% of people can have nail changes, and this usually looks like this, in little pits that we can see in the nail, so small little depressions, and sometimes there can also be roughening or whitening of areas of the nail. 1 in 4 patients with psoriasis can also develop arthritis, causing joint swelling and sometimes deformities. Another interesting aspect of psoriasis is that it also tends to occur in areas of skin injury. And so you can see the picture on the left from somebody sort of scratched the abdomen, and you can see that the psoriasis actually occurs as a line on this area. Okay, and for the second patient, you can see that there is this band of sparring over the mid-back. Okay, so what happened to this patient is that she actually went sun tanning and then got a sunburn, and you can see the psoriasis occurring over the damaged or the sunburned skin. Okay, and this is what we call a Koepner's phenomenon. Okay, so in psoriasis, it's very important not to irritate or injure the skin. So why does psoriasis occur? So psoriasis usually occurs when skin cells reproduce too quickly, and this is usually due to inflammation of the skin. So under the normal circumstances, our skin usually reproduces from the innermost layer and pushes out from the outermost layer. And this process usually takes some time, usually about 3 to 4 weeks. However, for psoriasis, due to inflammation, this is sped up significantly and can occur in 3 to 7 days. And so this results in accumulation of a lot of immature cells and thick rash and scales on the skin. So what triggers the skin inflammation in psoriasis? So as with most conditions, it's usually due to a combination of genetic factors as well as environmental factors. So we know that when a patient has one parent with psoriasis, the risk of having psoriasis goes up to about 14%. And if both parents have psoriasis, then this risk can go up to even about 40%. And various psoriasis-related genes have also been discovered. So what kind of environmental factors can trigger psoriasis? So these include, as mentioned earlier on, injury to the skin, such as through cuts, insect bites, or sunburn. Excessive smoking and drinking can also be a trigger for psoriasis. Stress, infections such as viral or throat infections. Hormonal changes such as with puberty, menopause, or pregnancy, as well as certain medications such as certain painkillers, anti-malarials, or even some blood pressure medicines. And these factors can also cause flares in people who have pre-existing psoriasis. So a combination of these genetic as well as environmental factors then sets off a series of inflammation signals, okay, that we can see here. So it's a very complicated diagram with lots of arrows. Okay, and this then causes this rapid growth of skin cells and the development of psoriasis. So how can we treat psoriasis? So earlier on, we shared that psoriasis is mainly due to 2 major components. So one is the inflammation of the skin, and then this then results in rapid growth of the skin cells. Okay, so the inflammation causing rapid growth of skin cells. So how treatment works is by targeting one of these 2 pathways. So it either works by trying to slow down the rapid growth of skin cells, okay, or we try to block the inflammation signals in the skin so that the skin becomes less inflamed. So this is just to show how psoriasis treatments have actually advanced significantly over the years. Okay, so first, starting in the 1920s, we have the old topical agents such as things like coal tar, and then to topical steroids, and finally to topical vitamin D creams. And then in the 1940s, we have the discovery of oral systemic medication. So these are mainly those that reduce the inflammation of the skin by immune suppression, or retinoids, which are vitamin A related medications. And subsequently, in the 1980s, the harnessing of ultraviolet light to treat skin disorders in the form of phototherapy. And more recently, in the last 2 decades, we've also seen the development of newer biologic agents, which are much more specific for psoriasis than some of the previous oral medications and are thus much more effective. And moving forward from there, now we also have biosimilars. So these are medications which are very similar in structure and function to the original biologic, but they can be produced at a much more affordable level. So this has really improved the cost as well as accessibility to biologic use. Okay, and lastly, there are also some new small molecule treatments that have been developed in recent years. Okay, so you can see that nowadays there are actually many effective and relatively safe treatments available to suit various needs. Okay, so very broadly, treatment can be divided into topical therapy, phototherapy, oral systemic therapy, which is taken usually by tablet or capsule, and lastly, biologic agents, which are usually given by injection. So we will first start off with the topical treatment. So this is usually the first line treatment for most of our patients, especially if psoriasis is relatively mild, and sometimes topical treatment is all that is needed. So commonly used agents includes anti-inflammatories, such as topical steroids. And these topical steroids come in many different strengths. So there can be up to even 7 different strengths of topical steroids. And we will adjust the strength depending on the thickness as well as the location of the rash. In certain areas, such as areas where the skin is very thin and we want to minimize steroid side effects, sometimes we may also use topical calcineurin inhibitors, which are non-steroidal anti-inflammatory agents. So other topical agents include that of coal tar, as was mentioned earlier. So these coal tar preparations try to slow down the growth of skin cells. However, we tend to use tar much less frequently these days in view of the smell as well as its tendency to stain. So we do tend to use a bit more of the vitamin D analogs, which include calcipotriol. And these also work by trying to reduce the rapid growth of skin cells that we see in psoriasis. But sometimes calcipotriol may cause skin irritation as well in some patients. And so combination creams together with topical steroids are also available, such as in the form of Devobat. So sometimes if psoriasis is widespread and it affects many parts of the body, then sometimes topical treatment alone may not be sufficient to control the disease. And then in that case, we may have to move to other treatment options. So one of the next treatment options that we can consider is phototherapy. Okay, so phototherapy is the use of a light to treat skin disorders. And we know that natural sunlight is beneficial for the skin for thousands of years. So now we have harnessed it in the form of phototherapy. And so this is just a very narrow spectrum of ultraviolet B, which is safer and more effective than natural sunlight because the other harmful and ineffective sunlight rays has all been filtered out. Okay, so phototherapy actually reduces inflammation of the skin, and the advantage is that it's external treatment. You don't need to worry about taking any medicine or worrying about any internal side effects. Okay, however, it can be a little bit troublesome because it is a bit of a slow process. And usually patients have to come 2 to 3 times a week for at least 3 to 4 months for a good treatment effect. So a next option, if let's say phototherapy didn't work sufficiently, or for some patients, they are unable to come for phototherapy due to various work or school commitments. And then the next thing that we can consider are oral systemic medications. And here are some of the common medications that we use, including acitretin, cyclosporin, and methotrexate. Okay, there are also some newer medications that I'll just touch a little bit on later. Okay, so we'll start off with the first medication, which is acitretin. So acitretin is actually a derivative of a vitamin A, and it works again by regulating the normal growth and development of skin cells. And the major advantage of this medication is that it doesn't affect the immune system. Okay, however, it's not suitable for females of childbearing age, mainly because it can cause birth defects, and it does require liver and cholesterol monitoring, and in some patients can also cause dry skin, nails, and mouth. Okay, the next two medications are both immune suppression medications. So how they work is that they try to reduce the inflammation of the skin by blocking of the immune system. Okay, and I put the word there in a sort of a non-specific manner because as opposed to the newer biologics nowadays, which are much more specific, this results in there being less side effects for the biologics and a little bit more for these immune suppressants, although they can also be very effective. So most of the time we do require monitoring for infection as well as organ side effects, but with good monitoring, they can be used effectively as well as safely as well. So what's new in oral medication? So there are two main medications that are relatively new. Okay, one of it is called apremilast. So this is a selective anti-inflammatory, and it's again quite a good option because there are no major organ risk factors. However, some caution on mood disorders as well as gastrointestinal side effects. And there's also a newer medication that is called deucravacitinib. So this is again more selective medication nowadays for psoriasis. However, this is not yet widely available locally. Okay, so lastly, moving on to the biologic agents. Okay, so biologic agents are protein-based drugs that are derived from the living cells in the lab. So actually they are engineered to specifically only target parts of the immune system that are overactive in psoriasis. So compared to the immune suppression medicines, which block a bigger part of the immune system, these only block the pathways that are known to trigger psoriasis and they spare the other pathways. So because of that, they are thought to be safer as well. Okay, so yeah, so as mentioned, they're more effective and also less risk of causing problems with the kidney, liver, or other organs. Okay, so most of them are given by injection or infusion. So the injection usually being a simple jab given at the tummy area. So this is sort of similar to a diabetic insulin injection, which most people can actually eventually do on their own at home if they feel comfortable. And while previously biologics were much more expensive, as mentioned with biosimilars, now this has greatly brought down the cost of treatment. So there are various biologics that are available now that block different parts of the psoriasis pathway. And so this is just to give you an overview of what kind of treatments that are available because there are so many different type of biologics now that we have available to use. Okay, so these are the various common signals that the biologics block. So one of it is called TNF alpha blockers. Okay, so this is one big group. Next, we have the interleukin 12 and 23 blockers. We have the interleukin 17 blockers and we have the interleukin 23 blockers. So you can see that there are actually many different options of biologics nowadays. And so how effective are these biologics? So this is a diagram just showing the estimated proportion of people who can get 75% improvement of the psoriasis in 4 months. Okay, so for an average sort of anti-TNF blocker, 67% of people can have 75% improvement. For the interleukin 17 or 23 blockers, you can see this goes up quite high to about 90%. Okay, and when we look at 100% clearance, that means complete clearance of psoriasis at 4 months. Okay, for the TNF blockers, it's a little bit lower at 17, but with some of the newer medications, this can go up to almost 50%. Okay, so this is just to show how effective biologics can be in control of psoriasis. So of course, biologics, while effective, are not entirely without risks, although they are safer than the oral medications we discussed earlier on. So there's still a small risk of infections. Okay, so usually we will still do some screening blood tests done before starting. Some biologics may also have specific risks, and of course, all these medications are sort of relatively new from the 2000s, and so the longer-term safety data is not known, although so far studies have shown that they are relatively safe. So furthermore, not every biologic will necessarily work for everybody, and it is possible sometimes that these biologics can lose effectiveness a little bit over time. And also do inform your doctor if you are planning to become pregnant or if you are taking a vaccine. So sometimes these may affect our choice of treatments as well. Okay, so there are so many options that we talk about and which is the right one for me. So there are many factors that we take into account when we are helping to choose treatment. So firstly, this includes things like the type of psoriasis, the severity of the psoriasis, whether there's involvement of any nail and joints, the treatment goals. So some people, they want complete clearance in a short time, and there are also some that prefer to stick to simple things like creams or phototherapy, and they want to avoid internal side effects. Other medical conditions that are associated, lifestyle factors, patient preference, and of course the cost of treatment. And so with that, usually we will formulate an individual treatment plan. So apart from the specific skin treatments which we have spoken about earlier, it's also important to complement this with a good skincare routine. And thus, for this next part of my talk, before I end, I'm just going to share with you a few tips on how you can look after your skin with psoriasis. Okay, so firstly, psoriasis makes your skin dry and easily irritated, and thus it is important to always use gentle cleansers as well as moisturizers. Take short showers of less than 5 minutes, and use cool or warm water and never hot water, because hot water can irritate or damage psoriatic skin. And while it may be sometimes tempting to try to scrub off the scales from your skin, do resist the temptation to do so, because we know that scrubbing can also cause irritation and cause a flare. So instead, try to pat dry gently instead. Moisturizers are then best applied within 5 minutes of your bath, and this will allow the lock-in of the moisture to be more effective. Okay, tip 2. So if you are using your topical treatment, do use it regularly as well as adequately. Okay, and when we mean regularly, we mean to use it regularly every day until the rash has completely resolved. Okay, and how much topical steroids to apply? So usually we use the fingertip unit as a gauge. So if we squeeze a standard tube from the tip of the finger to the first crease, then this gives you enough cream for 2 palm surfaces or 1 hand front and back. Okay, so thirdly, avoid scratching or irritating the skin. So as we mentioned earlier on, due to this coldness phenomenon, we can get psoriasis occurring on areas of injury. And you can see also, even after traditional cupping, we have a patient who, there's a reported patient who has psoriasis occurring over the areas of the burn. Okay, lastly, many people have scalp involvement, and so proper scalp care is also important, okay, because we want to ensure that the treatments can actually get to the scalp itself. Okay, so usually the first step is to soften and remove any scales. Okay, so this usually means we have to apply things that soften scales. So this can include things like olive oil or a cocois ointment, which we sometimes give. Leave it on at least 2 hours, or better still, even overnight. And then after that, wash off with shampoo, and you can use a fine tooth comb to gently remove the scales that can come off and not to scrub them off. Okay, so following that, you can towel dry your hair, and then after that, apply your scalp treatment. So to conclude, in the current landscape of treatment, psoriasis is highly treatable with very good clinical outcomes, and there are many treatment options. However, to achieve the best care with psoriasis, it is not just the appropriate skin treatment and good skin care. We also need to pay attention to other conditions such as that can be associated with psoriasis, as well as having healthy lifestyle measures. And so I will hand on to Dr. Sashen to tell you all more about these health conditions, as well as how we can manage our lifestyle in psoriasis. Okay, thank you.
All right. Thank you, Dr. Kirsten. Hope everyone can hear me. I will now be presenting on looking beyond skin, psoriasis, and your health. So in this segment, I'm going to show you how psoriasis is more than just a skin disease, but rather a disease that extends beyond the skin. Now, this matters because when we treat patients with psoriasis, we do not treat just the skin, but the patient as a whole. Now, if you were to imagine psoriasis as an onion, there's more than what meets the eye. Psoriasis has many layers to it in reality, and we'll be peeling away these layers. So, an outline for today's talk, we're going to look at the risk factors, trigger factors, most importantly, the comorbidities, and finally, putting this all together in the holistic management of psoriasis. So why do some people get psoriasis while others don't? Now, these factors are what we refer to as risk factors. Genetics is one. So now, a positive family history is a risk factor for psoriasis. If you have any relatives with psoriasis, puts you at a higher risk. Now, there are studies on the genes that were performed over the last decades, which have identified some genes that make you more susceptible to having psoriasis. Now, this one called HLA-C06 is one of the most important ones, but the genes alone are not necessary or sufficient to cause psoriasis. There are other factors as well. One of this, a big one, is smoking. And this is because smoking activates inflammatory immune pathways in psoriasis. And in humans, studies have shown an increase in inflammatory white blood cells in both the blood and the lung tissues in smokers. Now, the risk to develop psoriasis in people who have ever smoked was increased by almost twofold in a systematic review that they had done. However, interestingly, the most important risk factor for psoriatic disease is obesity. And as you know, there is an obesity epidemic all over the world currently, specifically in developed countries more than other countries. Now, 37% of people with psoriasis, more than a third, are obese. That's a very high number. Furthermore, obesity is also a known risk factor for all the conditions, the comorbidities associated with psoriatic disease. These are diabetes, high blood pressure, high cholesterol, and heart disease and depression. And this is why I counsel all my overweight and obese patients with psoriasis on the importance of weight loss. Some of the interesting studies out there were done in Sweden, where they took obese patients, some of whom underwent bariatric surgery to help with their weight loss. And as they predicted, there was a significant reduction in the psoriasis in those patients who had successful outcomes after bariatric surgery, meaning those patients who had loss of weight. What matters more is also the duration of obesity. So the longer you have been obese, the more severe your psoriasis. Next, we move on to trigger factors. So for a patient who's already at risk, let's look at some of the factors that tip the scale to make you develop psoriasis or cause you to have flares of your existing psoriasis. Now, these are some of the common triggers: hormone changes, be it pregnancy or menopause, stress, a huge risk factor in patients with psoriasis, infections, more commonly things like respiratory infections or throat infections, certain medications, and some groups are called beta blockers, steroid tablets, painkillers, or even malaria medications. Injury, as Dr. Kirsten mentioned, you should be very gentle on the skin to avoid scratching it, as that itself can trigger psoriatic plaques to form. Tattoos are another common cause. And finally, alcohol. Then we move on to comorbidities. Now, a comorbidity means more than one disease is present in the same person at the same time. So, for example, if you take someone having high blood pressure and diabetes, these are comorbidities. Now, this study from 2023 summarizes some of the most common other medical conditions that are seen in patients with psoriasis. You have high blood pressure, dyslipidemia, which means high cholesterol and high blood fat, basically, or high triglycerides, diabetes, atherosclerosis, depression, anxiety, fatty liver, difficulty sleeping, sleep apnea, vitiligo, osteoporosis, and a few others. And I'll go into detail on the most significant ones. The first is metabolic syndrome. And this is a poster from the social media website from the National Heart Center, which talks about metabolic syndrome. It looks at the three highs, and we're all familiar with these: high blood pressure, high blood sugar, and high cholesterol. Put these together with a high waist circumference, and you have metabolic syndrome. And this is something that's seen in about a quarter to a third of patients with psoriasis. So if you or a loved one has a high waist circumference, low good cholesterol or high triglycerides, high blood pressure, or high blood sugar, then they are considered to have metabolic syndrome. Now, while having one of these conditions alone comes with its own health consequences, it's even more concerning when they occur as a constellation, because this increases your risk of cardiovascular events, heart attack, and stroke. Now, this chart from 2007 looks at the prevalence of metabolic syndrome in different age classes. Let's first look at the controls, which are the white bars. You see that the first appears around 40s and increases from 50s to 60s to 70s. Now look at the black bars, which is patients with psoriasis. The onset of metabolic syndrome happens at a younger age, in the 31 to 40 age group, and at each significant age group, it's higher than the patients without psoriasis. So now, if you have psoriasis or have a loved ones with psoriasis, knowing this fact may actually help you change their life. The reason is that these are risk factors that we can change. They're modifiable risk factors, so there's something we can do about it. And as a dermatologist seeing patients with psoriasis, I work closely with my patients' GP or their family physician to aggressively control these risk factors like their diabetes, their high blood pressure, and their high cholesterol. So, prevalence of metabolic comorbidities in patients with psoriasis: 11% have diabetes, 39% are overweight, 37% are obese, and 38% have dyslipidemia. And these are alarmingly high numbers. Next, people with psoriasis are 1.5 to 3 times more likely to have non-alcoholic fatty liver disease. I'm sure you're aware of how alcohol can affect the liver. Drinking too much can cause cirrhosis. But it's not just alcohol, but just being overweight and having a lot of fat that can accumulate in the liver. It starts off, as you can see in this slide, starts off as just a healthy liver, which develops into fatty liver. Then you have fat plus inflammation leading to scarring. And that's what we call non-alcoholic steatohepatitis, or NASH. You have that scarring and inflammation going on for a couple of years, and then you have scar tissue. There's so much scar tissue that it replaces normal liver cells, and you have cirrhosis. At this point, the liver stops functioning normally. Some of these patients have it so bad that they even have to have liver transplants. So this is a very dangerous comorbidity, and it all boils down to controlling those comorbidities, such as a high blood cholesterol level, and exercising and having a healthy diet that prevents the development of non-alcoholic steatohepatitis. Now, in summary, looking at the cardiovascular disease associated with psoriasis, we have patients with psoriasis being 50% more likely to develop cardiovascular disease. We talked about a whole list of cardiovascular risk factors and what they can cause. So heart attack, stroke, obesity, diabetes, and high cholesterol. The risk increases with the severity of your psoriasis. And that's why it's important for these patients, or you, to have an annual health screen to always look for these conditions. But we've talked about all these risk factors and how they cause increased heart risk. But how does a skin disease have a risk to metabolic diseases? Well, it turns out that the skin and all the organs talk among themselves. Imagine a patient with lots of psoriatic rashes. Now, all of those skin areas that have psoriasis, they release chemicals into the bloodstream. These are almost like signals that go, and these allow the skin to talk to other organs. So the skin talks to the liver. It talks to the fat. It even talks to your muscle. So these are those chemicals that are listed. So Dr. Kirsten mentioned TNF-alpha, and that's one of the things that treatments block. So TNF-alpha is one of those signals, interferon gamma, interferon alpha. And some of these ILs, which are interleukins, all communicate. There's crosstalk between the skin and the liver, and that is what downstream causes more inflammation and causes atherosclerosis. You have deposits of fat or lipids in your blood vessels as a result of the skin inflammation. And that is what ultimately leads to heart diseases, or heart attacks and stroke. Next, we move on from the cardiac complications to the psychiatric comorbidities of patients with psoriasis. Now, depression. Around 20% of patients with psoriasis in Western countries are estimated to have depression. But you can ask, does having a skin condition result in depression? Is it just the stress associated with psoriasis that leads to depression? Or is it just a plain old coincidence that depression is frequently found in people with psoriasis? Now, there's increased prevalence of both depression and anxiety in people with psoriasis, but it's not just due to the pain and physical disability, but also due to the higher level of inflammation. Additionally, there are symptoms like your itch affecting anogenital areas. All of this can lead to depression and anxiety, specifically and more so when they're moderate to severe. So it's not just the physical burden of having a skin disease, but actually metabolic depression is what they call it. So you have inflammation from all your skin cells. You have symptoms of itch and pain. You have the stress associated with psoriasis. You have joint involvement of special areas, and finally, other conditions like obesity, which are also associated with depression. So it's complex. There are multiple factors causing depression in patients with psoriasis. And these are all important to address whenever we pick up someone who has psoriasis and also has depression. Now, it's easy for celebrities with psoriasis to speak up about their disease. 2022, Cara Delevingne, she went to the Met Gala, leaving her psoriasis rashes exposed. You can see that they're on her elbows. Entire body was painted in gold, but she left these open as a statement to draw attention to her psoriasis. Kim Kardashian recently talked about her psoriasis and how she was suffering with it. But it's less glamorous in real life. In this article, a lifeguard in Melbourne swimming pool picked out a girl who had psoriatic plaques. And you can see that they asked them if they had chickenpox or something contagious. Very often there is a misconception that psoriasis is contagious. It leads to severe isolation, so whether it's romantic relationships or even friendships. Of all psoriatic patients, 60% say that they have a major effect on their life. 90% feel stigmatized because of their skin. About half have significant psychiatric symptoms, and almost all, that's 91%, reported low self-confidence from their disease. Next, we have psoriatic arthritis, where the immune system attacks healthy joints. There's joint pain, there's stiffness, and swelling. And most often it's swelling of the ankles or even the fingers. You have stiffness early in the morning. Up to about 1/3 of patients with psoriasis can have psoriatic arthritis. You can even have psoriatic arthritis without psoriasis. Now, in some patients, this joint pain comes before the appearance of skin changes, but in some patients, the joint pain comes after the skin rashes have been there for a while. Anti-inflammatory drugs, rest, and physiotherapy are what we often use to treat psoriatic arthritis. Now, it's important to detect this early because finding it out early and treating it can prevent non-reversible destruction of the joints. So this summarizes all the important points for psoriatic arthritis. You have joint pain, could be in the foot. You could have swollen fingers and joints. It could reduce your range of motion. You may have stiffness in the morning. Could cause eye pain and redness, and even nail involvement. Psoriasis doesn't affect just the patient, but it also affects loved ones too. Now, a survey was done recently on how psoriasis impacts family members. Now, 70% said that it impacted household work. A small amount had psychosocial pressure. It impacted social life, not just of the patient, but their family members as well. And it also impacted social relationships. So some patients say they had no social life when they were worried about how their loved one was feeling. Some people feel embarrassed because of their family members. All the family members had to brush themselves off because of all the scales of their loved one. Absenteeism is a huge problem in families with psoriasis. You have to take MC, you have to take time off to take your loved ones to the clinic. And finally, family members also stop taking care of themselves because they're so busy that they've been taking care of loved ones with psoriasis. It comes in the way of romantic relationships, affects patients' love lives. And this slide just summarizes all the different facets of family and social life that psoriasis can impact. So what does all of this mean? Now, coming back to the onion layers of psoriasis, you have a genetic predisposition, you have risk factors such as obesity and smoking that tip the scale, you have stress, drugs, and infections that can trigger flares, but then you have these comorbidities that can lead to not just problems such as, the individual complications of high blood pressure or diabetes, but overall increase your risk of cardiovascular disease, such as heart attack and stroke. These are modifiable risk factors. And finally, you have diseases such as psoriatic arthritis that can impact patients very significantly on a day-to-day basis. Now, the take-home points from this, the most important risk factor for psoriasis is obesity. Now, the comorbidities include diabetes, high blood pressure, and dyslipidemia, things we can control. Depression is not just a consequence of the disease, but an actual comorbidity as well, which should be taken just as seriously as the others. Now, to provide holistic management of psoriasis, your doctors, that's us, the dermatologist, and your GP or the family physician, will manage not just the skin, but also all the other comorbidities as well. We manage psoriasis as a whole. That involves treating the skin psoriasis, managing lifestyles and triggers, treating the joint and metabolic associations, and addressing the mental and social health of the person with psoriasis. And this can only be done when the dermatologist partners with, the family physician or the GP and coming up with a personalized treatment plan. And that's what we do in our psoriasis clinic. So what can you do as a patient with psoriasis? Or what can you advise to your loved one who has psoriasis? The most important would perhaps be, other than seeing a dermatologist for treatment, to make healthy choices to reduce psoriasis flares. And that includes quitting smoking, limiting alcohol, maintaining a healthy weight, exercising, eating a healthy balanced diet, getting screened for high blood pressure, cholesterol, and diabetes once a year. And this is not negotiable. It's not something that can be skipped. Managing stress, and this is where family members play a big part. And finally, joining a support group. Now, the Psoriasis Association of Singapore, which I'm also part of, is a very useful support group for patients in Singapore. I've just put up their website, the link to their website over here. They have a World Psoriasis Day coming up as well, which is something that you can definitely, this website is something you can look at if you want to meet other patients with psoriasis and hear more. So thank you very much for your time and happy to take questions. Hi, I can take the first question. So the first question is, will eczema become psoriasis? So that's a very good question because the two conditions can look very similar. They are both scaly, they are both red, they can both be itchy, although one more than the other. However, while they both look very similar, they're caused by different pathways. So as Dr. Kirsten showed you in that diagram previously, there are different cytokines or different cell signals that lead to psoriasis downstream. Now, eczema has a different set of signals that cause eczema rashes. And as you know, eczema also has a very strong genetic tendency. Patients with atopic dermatitis or eczema that starts off in young age often have other conditions like asthma or sensitive nose, allergic rhinitis. And psoriasis generally does not start at such a young age, although there are some exceptional cases, usually at an older age, so with peaking around the 20s, 30s, but another peak around the middle age or so 50s. So eczema will not become psoriasis because there are two different pathways.
Yeah, thanks, Sashan. Yeah, so I agree with you about the eczema usually doesn't become psoriasis, but eczema is relatively common. So it is possible actually that sometimes somebody can have psoriasis. And then you can also, for example, due to excessive hand washing, and you deplete the oil protection from your skin, that you can also get eczema later on as well. Yeah, so it's possible to have both at the same time. Okay, I think there's also a question about arthritis, so I guess I can take that. So is there any indication for blood work to confirm psoriatic arthritis? So usually when you see us in the clinic, you will see us sometimes asking about whether you have any joint pain, swelling, or stiffness. Okay, so sometimes if you do have joint pains and swellings or stiffness, especially early morning, And for example, you get a back that is very stiff in the early morning, or the fingers are very stiff in the early morning. And as you move and exercise, it actually improves. Then these sometimes may make us suspect whether you can have early psoriatic arthritis. Okay, so this is as opposed to arthritis due to age and wear and tear. So some people have, say, like knee arthritis, right? They call it osteoarthritis when we get older. So those are usually mechanical in the sense that it tends to get worse when you use it more, right? So at the end of the day, you may get the knee feeling very painful and swollen at the end of the day. Whereas for psoriasis, it's usually more inflammation driven. So it tends to be worse actually when there is inactivity. So if there are things to make us suspect it, then yes, we may consider either getting you to see the joint doctor or the rheumatologist, or we may try to do some tests to work up. So what kind of tests we can do? There are blood tests, mainly looking for inflammation markers. So these are not specific to say that you definitely have psoriatic related arthritis, but they can, together with what we see on the joints and the skin, put together to say that yes, it looks like there is a high level of inflammation in the blood, and so we think that you may have early psoriatic arthritis. Sometimes we can also consider doing x-rays or even other forms of imaging to screen for arthritis if we suspect it. But otherwise, if you are normally well and don't have any symptoms, we do not routinely do screening or blood tests to look for psoriatic arthritis. So I think there's a question on metabolic syndrome as well, right? Maybe Session, you want to answer that. Yeah, does metabolic syndrome cause psoriasis or the other way around?
Hi, thanks for that question. So as I've mentioned in my slides, there are some risk factors for psoriasis, such as obesity. So increased waist circumference is part of the metabolic syndrome. So obesity does increase your risk of getting psoriasis, but the other conditions are more conditions that are seen together with psoriasis. So if you're someone with psoriasis, there's a higher chance of you having these conditions at the same time. So in a sense, yes, metabolic syndrome is found more commonly, more prevalent in patients with psoriasis. So it's always good to have those controlled.
Doctor, do you want to answer this question?
Oh, I've already answered this question. Yeah, maybe we can pick up some from the chat.
Oh, I've answered this question in the chat just now, but I can just briefly explain again. So the question is, can the mRNA vaccine trigger or exacerbate psoriasis? Now, as you know, vaccines work by causing the immune system to develop immunity to a particular virus, even say, for example, the flu virus or the COVID virus. Psoriasis, as we've taught you, is mediated by, it's an inflammatory disease. So the immune system is involved. Because of this, a vaccine can certainly trigger, not all the time, but sometimes vaccines can trigger or cause flares of psoriasis. So if it's a patient who's already had psoriasis, some of them come to me after they've gotten a vaccine saying that, it flared up after the vaccine. Not just a vaccine, but a viral infection as well. So yes, vaccines can trigger or exacerbate psoriasis.
Okay, my husband has psoriasis and my daughter has eczema and rhinitis. What will be a risk of psoriasis later in life? So usually if there's one parent that has psoriasis, then definitely your daughter's risk of getting psoriasis will be higher than the normal population. So of course it varies between individuals. However, in general, it's thought to be around 10 to 15% a risk if one parent has psoriasis. Okay, so the next question is, does treatment lead to full recovery or lifetime treatment? Okay, so This will really depend on various factors. One, of course, is the severity as well. We do have some patients when they have a quite mild psoriasis that sometimes with creams and all, it can be relatively well controlled and it can be quite quiet except for certain triggers that cause it to flare. However, for most patients that have quite extensive psoriasis, this usually shows that the psoriasis is quite active for most of the time. While the treatments are very effective, I think earlier on we were discussing some of the treatments, right? So some of the newer treatments, even almost 1 in 2 people can be completely clear from the of psoriasis, and that sometimes can be life-changing because it really clears up the psoriasis on the skin. However, most of the time for these kind of patients, it is going to be a chronic condition. So the treatments are sort of indefinite in the sense that they can control it to a very good level, but it may not be possible to completely come off it. So what some patients do sometimes they try to cut down the treatment to the boundary at which they can have good control, and that will be continued on for in a way a lifetime basis. Okay, maybe we can take one more question. Maybe Sashan, is there a kind of food that will help with psoriasis? And what does it mean to limit alcohol?
Right. Thanks for that question. So regarding the food, so there's no specific type that would say make your psoriasis better or make your psoriasis worse. However, we focused on the metabolic syndrome before. So any food that helps reduce your risk of high blood pressure, high blood sugar, or improves your cholesterol profile will help in managing both psoriasis and the comorbidities. So for example, if you're eating more whole grains, fruits and vegetables, high fiber, all of that helps with increasing your good cholesterol, your HDL, and lowering your bad cholesterol, the LDL, avoiding saturated fats. So for example, the fat that you find in animal products. So minimizing that, controlling that also helps. So overall, the goal is not one silver bullet food that reduces your risk of psoriasis, but having a diet in general, a balanced, healthy diet that minimizes your risk of these metabolic conditions, diabetes, high blood pressure, and cholesterol, a heart and healthy diet, basically, which will help. Weight loss will also help with psoriasis, and diet's part of that. The other question was with regards to alcohol and how much alcohol should you limit to? Now, this is a question that some of my patients ask as well. And the actual answer is it depends. So I have some patients who, say, for work reasons, have had to drink in the past on a daily basis. I had a patient who, say, for example, worked with clients, had meetings daily for which he had to drink, or a patient who was working in a bar as a bartender and had to drink on a daily basis. And he found that when he changed his job and wasn't drinking on a daily basis, immediately the psoriasis improved. Maybe, yes, he had drunk once in a while socially afterwards, but there's no absolute number. It would depend on how well you metabolize alcohol, your tolerance for alcohol, and how much you drink. So it's hard to say an exact number or how much alcohol, but cutting down on alcohol will definitely help in your psoriasis control.
Okay, we have a few minutes more. Okay, is there any specific type of clothing suitable for psoriasis patients? Okay, so in general for psoriasis, like what we mentioned, we want to reduce any irritation of the skin. So sometimes if we use sort of a woolly clothing, right, and some of those wool, it can tickle or irritate the skin. So we want to avoid these. So I think plain cotton clothing is fine. Don't wear it too tight. And also some patients, especially if they have active psoriasis, some patients may choose to use sort of white or lighter color clothing because that sometimes also helps to make any scales that come on a bit less obvious. Okay, thank you everybody. So I think we have come to the end of the session, but I think there's still a few minutes. So what we will do is that we will try to answer the questions that are within the Q&A box. Thank you for your kind attention.